She's a 72-year-old female presented with massive ascites. So in this specimen, we see scattered very tight cluster of typical cells. And so you go to high power, you see the cell have these nice glandular arrangement with overlapping nucleus. The nuclear chromatin pattern show classic vesicular pattern, so you can appreciate that like very tiny like bubble inside these nucleus. And we also see prominent nucleolus. So this is a classic morphology for adenocarcinoma. Additionally, you see in the cytoplasm there are some vacuolation. So this is a female, and this is a ascites specimen, from an older female. So the most common scenario would be coming from the gynecologic tract. However, if you take a look of these tumor cell, it does have some like a tubular, a little bit like an intestinal like a feature with a nice luminal border around these tumor nest. So the patient has these clinical evaluation and identify a large pancreatic tumor. So this is likely coming from the pancreatobiliary tract, and the morphology is also compatible. So the patient already have a biopsy, and so we don't need to do any stent. Otherwise, if there is no focus, we will do PAC to confirm or rule out the gynecologic origin first, because this is coming from the emergency department. So the second case, this is a 54-year-old male who had a past history of lung cancer. The lung adenocarcinoma is negative for EGFR mutation. However, it is positive for BRAF V600E mutation, which is a relatively rare mutation in lung cancer. It's less than 1% of non-small cell lung cancer. So in these specimen, you can appreciate there are a lot of loosely cohesive cells. A lot of them actually have these mesothelial-like appearance. You can see intercellular window over here. So sometimes in the adenocarcinoma, the presentation can be really difficult to distinguish from the mesothelial cells. Especially like in this cell, you do see some like a lacy skirt kind of pattern. It's very common in the mesothelial cells. But here you see a more tight aggregates with prominent nuclear polymorphism. So you see this is a very big cells. Right next to it is a much smaller cells. And here you do see some mitosis. So mitosis is not a definite sign for malignancy, but if it occurs more frequently, it does suggest possibility of malignancy. So I think in this specimen, it is relatively monotonous, and it is not very easy to appreciate the so-called two-cell population. And it seems to me that the two-cell population are very similar, so it all mix up together. However, you can still appreciate that they are definitely some highly atypical cells in cluster in these specimen. And if you go to the cell block, and you can tell that basically there is no normal mesothelial population, right? It looks like every cell is tumor cell. So from that cytospin specimen, you can tell that although a lot of them looks like a mesothelial cell, but basically they are all tumor cells. So the patient does has a very high tumor burden. So the next specimen is a new patient, 70-year-old male with right side pleural effusion. So for these specimen, again, you see mostly tight cluster instead of like individual cells in the background. And these cells arranged in these very tight three-dimensional cluster with a arrangement of like a glandular feature. So if you pay attention, so this is quite different from the pancreatobiliary like a feature that we see a more smooth border, a luminal border type of like pattern, but this is all like a you see these like a scalloping type of pattern. So this is more common in the lung cancer as well as in the gynecologic origin like adenocarcinoma. So this looks like a typical lung adenocarcinoma because this is a new patient. And we do have a very good cell block. So again, you can see this is very similar to the prior specimen of lung cancer. So we will do TTF1, and if it is positive, the clinician will use this specimen for EGFR testing. So the next specimen is coming from a 62-year-old female with ascites. She had a past history of breast cancer. So if it is a metastatic specimen, it's already go beyond the diaphragm. Okay. So in this specimen, I find it's quite difficult because there are like a lot of these very tiny cluster, but the nuclear pattern is not very well preserved. Sometimes in this situation, it could be resulting from the prolonged preparation. So I think the patient may be taking this specimen on Friday, and it's sent here, and so it was sitting in the like a refrigerator for the weekend. So it is a little bit difficult to appreciate the nuclear feature because it's already degenerated. Okay, so we do not see a typical feature like a very prominent nucleola in large nucleus. We didn't see that. What we only see is it forming a relatively tight cluster, right? So these on low power, you take a look and you think, oh, this could be cancer. But on high power, I would say that the details between these tumor cell versus the mesothelial cell are really subtle. Okay, so sometimes you need to have the low power pattern. You need to trust the low power pattern because the preparation, the fixation like issue. Okay. So the patient does has a cell block. So sometimes if I am not able to have a very confident interpretation of the cells, I would still do the immunohistochemistry because I think the morphology is a little bit vague to me. Okay, so in this cell block preparation, we actually do not see a lot of cell in cluster, like very, very loose cluster. And for me, I think it's kind of difficult to tell apart which is normal and which is tumor. It's a little bit difficult. I think this is mostly because of the delay fixation, prolonged specimen sitting in the refrigerator. And sometimes if it has some degeneration, our staining doesn't work very well. So this is a MOC31 stain. So you can definitely see there are some larger cell in cluster positive for MOC31, some individual cell, but in the background there are some more smaller cell with a partial like a staining. So I think this can also be due to the delay fixation. For the breast, we would like to do the marker for GATA3. So you can tell that the GATA3 seems to have better preservation. And again, you do see in the background single cells, large single cell compared to the relatively smaller histiocyte mesothelial cell, and the cluster of cell is much easier to appreciate. Okay, so we confirm in this specimen actually there are a lot of tumor cell instead just a little, but it's a little bit difficult to tell just by the cytospin preparation. Okay, so this is positive for metastatic breast cancer. Sometimes the clinician will want to have a repeat thermal marker. In this situation, the fixation is actually not very ideal, but because it would be the only specimen, so we would still probably do it. So the next specimen is it's an aspiration specimen. This one is relatively uncommon. This is a aspiration touch imprint from liver. Okay, so we rarely receive this type of specimen. So it is a cystic lesion in the liver. In the background, we do see a lot of like a degeneration, cystic type of pattern, maybe some tumor, like a necrotic tumor cells. I should not jump too quickly saying that this is tumor, so I would just say, okay, some degeneration, some cell shadow, unknown if this is true tumor or not. So for interpreting this type of specimen, we will still need to look for the well-preserved cells with nice morphology that we can make diagnosis. So there is an interesting group of cells that you do see increase size of the nucleus, prominent nucleolus, but you also see the NC ratio is low. The cytoplasm is quite abundant, but infiltrated with a lot of neutrophil. So this looks like a phagocytosis. It's very rare that we will see in the aspiration specimen, but this is kind of common that we will see in the glandular, a typical glandular lesion in the pap smear. So we do see like degenerative atypical cells, some in a really small cluster, some with more vacuolated cytoplasm. But to me, for these specimen, I can probably only call these atypical. So we only see some atypical glandular cells with a cystic degenerative background, which is difficult to tell if this is a tumor or not, because those kind of cells can be induced by cystic change. So we go to this direct smear. Again, we do see, because this is a direct smear, so the background material is more preserved comparing to the liquid-based specimen, because for the liquid-based specimen, we will wash out most of this background material. So in the direct smear, you do see it looks much more like necrosis, right? You do see a lot of like cell debris in this background. So again, we need to look for like more preserved cells. So in this cell cluster, you do see it form a very tight, like a tubular type of pattern. 你懂吗？是什么？好，那你再寄回来，谢谢。Okay. So, and again, you see in the luminal border, it does contain some like yellow or oranginophilic mucin material. So the patient actually had a large pancreatic mass, and the clinician suspect to have liver metastases. So these morphology is compatible with pancreatobiliary tract origin, right? Okay, so I think for these direct smear, we can just confidently call these positive adenocarcinoma, and it is likely the pancreatobiliary origin. So the next specimen is parotid aspiration from an elder male. So again, in the background, we do see some cystic degeneration, some cell debris, right? But again, we are not jumping too quickly in saying that this is necrosis, because we know in some parotid gland lesion, it can have some degenerative cystic background that looks a little bit like necrosis, but they are not. So in these specimen, we only have a few cluster of epithelial cells. It has quite abundant cytoplasm. The preservation is not very good, but it looks like oncocyte. So it would be nice if we can find a more like a well-preserved cell cluster to code these Watson tumor. So we go to the direct smear again. Okay, so here we do find there are more like a larger fragments of cells, and with these nice honeycombing, very flattened appearance. And with this background cystic degeneration, this is compatible with a Watson tumor. And for, so we have more these nicely arranged honeycombing fragment of oncocytes. And I remember yesterday I see some tall columnar cells, but it's difficult to find, okay? So this is a benign tumor compatible with a Watson tumor. So the next specimen coming from a 79-year-old female. She had the history of non-small cell lung cancer, which was just diagnosed, and this is throughout the evaluation. There is a subepithelial mass in the stomach was identified by the image, so she received these US guided aspiration. So in this specimen, instead of the usual like adenocarcinoma where we often see, we see these highly spindle, like elongated cell into a cluster. So this is the morphology is compatible with a GIST. Okay, so we will wait for the immunohistochemistry from the biopsy specimen. But overall, I think it is the mostly compatible just by cytomorphology. It is a GIST. Okay, so these cell high cellularity with highly spindle cells. In the direct smear, usually for the loose stem, we will see some like extracellular matrix material, but there is no cells on the loose stem, so we won't be able to see. But in these liquid-based specimen, these looks pretty good for a GIST. So we have a few pap smear. This is coming from a 71-year-old female with postmenopausal bleeding. This is the most frequent like a cause of visit for elder female to the gynecologic outpatient department. In this specimen, just on low power, you see a lot of cell and with a lot of blood, right? So it is very, very bloody, and with a lot of these larger like fragments of cells. It is mostly in tight cluster. So in the background, we see a lot of PMN, okay? And there are these like a tight cluster of cells. It looks quite like degenerated. So at the periphery, you can appreciate that the chromatin is all like a beating, like a clump together. I would say the cell is not particularly big. It is kind of small, so also compatible with the marked degeneration. And I think for these specimen, it is very, very difficult that we can confidently call this adenocarcinoma. I think most of these cells represent the stromal cell with a lot of degeneration. We do not see any good like area with a more clear glandular feature with a more like a definite type of atypia that we can safely call these adenocarcinoma. So for this specimen, I'm calling it AGC, atypical glandular cell, and favor neoplasm. I think we do not see any cell that we can confidently call this adenocarcinoma. So this is very important. When we want to call definite malignancy, it's better that we see a well-preserved cell, okay? So the patient actually is a frequent visitor. She has been evaluated by the uterus ultrasound, and the endometrium is actually not very thick. It's only 1.2 or 3 centimeter. So I'm not so sure what's happening for this patient. Yeah, so it's much better that we don't call these cancer right away. Particularly in the background, you do not see any like a necrotic pattern, only the hemorrhage and inflammation. So the next specimen, this one is also kind of annoying. So one of the most like a challenging issue is to distinguish that the like a parakeratosis versus it is a true like a precursor lesion. For this specimen, we do see some spindle cell with more like a hyperchromasia, and some cell does has a little bit increase of the size of the nucleus. So here you see hyperchromasia, but it looks a little bit degeneration. And here you do see it's getting bigger, but you do not see any good like focus suggests that it is a true HyCl. Some screener, whenever they see a spindle cell, they would be really panic about could it be a invasive squamous cell carcinoma. But if you want to diagnose squamous cell carcinoma, you really need to see some tumor diastasis. Okay. So sometimes if there are some chronic irritation, it can cause the superficial squamous cell with these morphologic pattern. But I would say for the case, I think the atypia is like exceeding the range of reactive type of atypia. And so for this specimen, I would be willing to call this atypical squamous cell, cannot exclude HyCl. I see the amount of cell is a little bit too much, and ascus is a little bit too low because of those like higher NC ratio spindle cells. So I think it's better to call these AGC, cannot exclude HyCl. The patient actually has been followed in the outpatient for a while, possibly around 2 years. We've been calling the lesion ascus before, and the patient received biopsy and there is nothing. But for these specimen, I would still want the patient to do a colposcopy examination. So the last time we called these ascus, they decided to follow. So this is the 3 months follow-up smear, and we still see this type of like cellular change. So I'm calling these ascus highs to persuade the clinician to just do another biopsy, because I think these need to be evaluated. Okay, so that's all the case for today. Thank you.
Thank you. 主任，那个我们那台日交流那个 case， 不知道是
什么时候会来？不晓得。
因为我好像看到
他已经寄给你了吗？
官网上面有那个这个 case
对，可是他
information， 好像没有说哪些是。